I'll try and give this a go here. Hui nutsa. I'll say it one more time, so I'm going to try and say this right. Hui nutsa. We are one. It's what Shane had been talking about at various points today, and it really is at the core, I think, of this workshop. Engaging and partnering, and there's a wealth of experience at this table, and I'll just do a quick round of introductions. CATIE McDonald. CATIE has a background in nursing, Masters of Science, specializing in community health nursing. She's been a member of the Northern BC First Nations Coalition since its inception, is a co-lead for the Stop HIV/AIDS project in the North, prevention director. Next over is Emma Palmentier, and Emma's been the chair of the Northern BC First Nations HIV/AIDS Coalition since 2006. She's held various political positions over the years: Vice Chief of Carrier-Sacani Tribal Council, Chief of Lake Babine Nation for 3 terms. I've had the wonderful privilege of being able to go and visit and be a guest at Lake Babine. She's been general manager for various First Nations organizations and many others, and she originates from Burns Lake. Janine, the list doesn't match up. Janine has been with BCCDC for 17 years. She's worked with the Street Nurse program for 14, has been played a key supporting role for the Chimamuk Aboriginal program for the last 12 years, and Janine has recently completed her Master's in Science in Nursing. And then we have Sarah, and Sarah is a Métis woman who joined the Chimamuk team as an educator. Sarah's background is in teaching, and she holds a degree in psychology and sociology. And Diana Day, who's the leader Aboriginal Community Development Engagement, VCH. She's a member of the Wolf Clan from the Oneida Nation, working in a variety of capacities in community development and social services at the local, provincial, and national level. She has a BA honors degree in psychology, but most importantly, a mother of 2 children. And hot off the press, Deputy Provincial Health Officer, Dr. Evan Adams. He likes long walks on the beach. Under the direction of the Deputy Minister of Health and the Provincial Health Officer, Evan provides expert medical advice, support, and guidance regarding Aboriginal health policy development programs and other initiatives. A long list of awards and distinctions. He's probably spent most of your life in school, getting masters and certifications, which aren't listed there. And that's our panel, so I feel very honored to have this group here to talk about this. And I think the plan is for them to do a presentation for the beginning and then transition into some dialogue with everyone around the room and answer questions folks have. So with that, I think, Evan, I've been told you're up to bat. You're first.
Thanks, Chiro. I won't tell them how you know I like long walks on the beach. Great. So my job today is really just to start us off, because there are going to be some really, really wonderful ideas about how to partner with First Nations with our intended new activities and to continue this really, really great work that actually has been happening for quite a long time. I think there are a few of us here who have been working in HIV/AIDS for, gosh, going on decades now, eh? I can't believe it. That previous work and those previous workers and those previous organizations really have informed what we wish to accomplish, which we've been describing today. And I also don't want to bog down in specific interventions. As we all know, there are literally hundreds of things that we can do to support our communities and support testing in persons living with HIV and AIDS. And I don't want to debate them, just because even interventions like fighting racism can help, but they're not necessarily something that this crowd is, or maybe you are going to engage in that, but some of you have skills that might be used in other areas than fighting racism. So let's begin. Oh, my name is Tlesla. Thank you, Evan Adams from Slyman First Nation, and I'm a family doctor, but I have a master's in public health, and I work in public health now in the Office of the Provincial Health Officer. Just to remind you of our demographics, we number about 200,000, about 1 in 20 British Columbians is Aboriginal, and we have 203 First Nations. This is a very important distinction. Some of us live on reserve, but lots of us live off reserve, and not all of us are Indians or First Nations. Lots of us are other. So just a reminder that 55.5% of the First Nations population does not live on reserve, and that 72.7% of the Aboriginal population does not live on reserve. And very much in the past, on-reserve populations have taken a lot of focus. They are overemphasized when we look at Aboriginal populations. And there is a lot of diversity, and there are many, many amongst us in Aboriginal populations that we must focus on. So the target is not all Aboriginal populations. Our target is populations that are at risk, particularly from the data, sex workers, mostly women, men who have sex with men, and that persons living with HIV, AIDS are our partners in this area, and we must hear them, and IV drug users. So here's why. We've heard many reasons. I don't want to spend too much time here. In 2011, First Nations Aboriginal people comprised 15% of new HIV diagnoses in BC. In 2011, First Nations and Aboriginal women comprised more than 50% of new HIV diagnoses amongst women in BC. And we need to understand why those particular women, why these Aboriginal women are at risk or are vulnerable. We need to qualify that and quantify that. And we comprised 18% of new AIDS cases in 2010. We're progressing to AIDS and to HIV-related mortality still at quite a rate. I'll show you some data along those lines. And so why is that occurring? Clearly there are obstacles to care. As was described by Michelle de Groot earlier, we do have some key agreements. These are formal agreements for us to attend to the health of Aboriginal people. When I started my work with the provincial government in 2007, it wasn't unusual for me to ask, what are we doing for Aboriginal people? And for someone to say, well, we think we're catching them along with everyone else, like they're being helped along with everyone else. We don't really know because we don't really have data, but we suspect we're doing a really good job. And that kind of lack of reporting is, I think, what we want to be improving upon and saying, well, actually, we've looked closely at our practices, we've looked closely at our data and our outcomes, and we've examined our practices, and we know either very well that we're not doing a good job, or that we're doing a moderate job, or we're doing really well, or that we don't really know what's happening out there, and we should find out more. That's a much better report to me than saying we think we're doing a great job. As was described earlier, the First Nations Health Authority has a wellness model. This is a model that has been endorsed by the chiefs and was done in consultation with First Nations workers and First Nations clients. It's a very holistic approach. First Nations people are very good at, I think, being holistic. And so looking at the entirety of their population, for instance, community viral load, or looking at the totality of the person, even if we could cure them of HIV/AIDS and then we return them to their homelessness, isn't necessarily the best that we can do. They understand that quite intrinsically, and they have been very clear to us that they would like for us to have a more holistic and wholesome approach that is supportive to them, and one that incorporates their current knowledge and practices, in that we grew up in a certain way. We grew up with certain values about how to be good people and healthy people, and how to support each other and to be strong, and those need to be incorporated into our current plans. We can't just erase their histories and look at them as empty vessels to be filled with our knowledge. So my office, the Office of Provincial Health Officer, monitors the health of British Columbians. We also try and monitor the health of Aboriginal people. Our data is not the greatest, but we do have about 65 health indicators we track. We reported on them for the first time in 2001. We updated that in 2006 and actually got a trend. 2001, of course, was our baseline. 2006, we got to have a look at some trends. By and large, we have made improvements in some areas. There have been some areas where there has been no change, and there were a few very dramatic health outcomes. This was probably the most dramatic. This is HIV-related mortality for Status Indians, 1993 to 2006. That's the top line, and HIV-related mortality for other residents of BC is the bottom line. And as expected, around 1995, 1996, with the introduction of heart, HIV-related mortality for other British Columbians dropped and flatlined. These are the actual points here. This is the trend line. And you can see that for Status Indians with HIV, their HIV-related mortality, even with heart, continued to climb and climb and climb. And so we had to ask, even in the presence of a magic bullet, of this, of this magical pill that didn't cost them anything, it wasn't reaching their mouths, and HIV wasn't turning into a chronic illness for our population. So what were the obstacles to care? And so we asked around, what are the obstacles to care? Of course, geographic isolation or geographic access was at the top of the list. Very easy, facile answer to get to. But we kept asking, and these are some of the things that we need to address in looking at Aboriginal clients or First Nations clients in our efforts today and tomorrow and the coming future. The other is social isolation, that for some members of our communities, not all of them, but for some members of our communities, they're isolated from the general population, or they're isolated from caregivers, or they're isolated from HIV caregivers, and they're not receiving help. There is a lack of confidence in system and personnel, and I do spend a lot of time providing reassurance to First Nations communities that you can go to your doctor and expect good care. You'd be amazed how many First Nations people don't expect good care from their physician. And I have to say, well, actually, lots of them work really hard, and they're very well trained, and they're conscientious. And remember, there's probably a doctor in your past who saved your life. And not all of your experiences with doctors or other healthcare personnel is necessarily going to be negative. That their lack of confidence in the system sometimes isn't enough for them to stay away. So we need to engage in that conversation where they report to me that they can go somewhere and get really bad care, or they can go somewhere and have a colonial experience where they're disempowered and where they're made to feel terrible when they're actually seeking help. And I have to say to them, I know this place, or I know those personnel, and I can send you there. They will help you. Their previous experiences need to be discussed, and I've been very lucky. I get to speak to, tens of thousands of Aboriginal people in this province, and almost to a person, they report a negative experience with the healthcare system where they were made to feel really quite awful. And they would like to debrief about that. They describe an experience like I brought my mom to emerge, and the nurse said to the doctor, "Could someone please help this patient? She's really complaining a lot." And that was her report to me of what had happened. Her mother then passed away that same evening, and she left there with quite a bitter feeling that somehow, perhaps, her mother had received poor care because of the color of her skin. And then I have to speak to them and say, well, someone saying, "Could someone help this patient? They're really complaining a lot," sounds, I can see that that could be said in a way that is really hurtful. I also know it could have been said with the best of intentions. I wasn't there. I take your story at full value, and I see that in your loss, you're really hurt. And I would like to know if you're receiving substandard care, or if healthcare workers are racist or negligent toward you. You should be allowed to wonder that, given our social context, and I can ask what's happening with workers in this place. Those are things that need to be addressed in order for us to make sure that our clients are engaging with every confidence. That there are compelling distractions. I worked in the downtown east side for 5 years. I understand that some First Nations people living on the street who are working as sex workers have addictions and psychiatric issues, that they have issues around housing and access to their children, and issues with the law and with being harassed, and with racism and trying to access care. Those are all distracting from trying to remember to take care of yourself and remember your pill regimens and your appointments with specialists and the like. And that the number of compelling distractions for First Nations, to me, appear to be a little bit higher than for everyone else, just enough to tip them more often into chaos. And if we can help with helping them to organize, or to help them with these distractions, then I think that kind of social support or organizational support, that kind of outreach could probably make a lot of difference. Of course, the social determinants of health, and I'm glad to report that in our tripartite agreement, our workers, the First Nations Health Authority's 300 or so workers, have the permission to deal with the social determinants of health in their work plans. They're not just meant to work within their silos, like if they're an early childhood educator, or if they're a policy pundit. They don't just have to work within their small title. The expectation will be that they will deal with the social determinants of health, whatever those are identified to be for them. And health literacy. I always remember being part of the Vanguard project as they tracked thousands of us gay men as we seroconverted, and they gathered demographic information and, of course, data about our behavior to see, who was seroconverting. And of course, it was those of us who were poorer and underemployed and had less education who were the ones who were seroconverting more, or tended to seroconvert more often than those who were better off and better educated. And so ditto for our communities. They are hungry for information. They see the sense in cooperating. They do want to know about HIV and AIDS and its prevention. They do see the sense in protecting their children and families and their women. Absolutely, it's not a problem in that regard, but sharing our information in a way that they can receive it in a good way is our challenge. Community members are really concerned around privacy. So part of what we're doing, because we, the First Nations Health Authority in the province of BC and the federal government, are proposing to share data with each other. For instance, we have a data access request to use the First Nations client file, which I will describe later. I'll describe that file later. But to share the First Nations client file with the BC Centre for Excellence so we can get First Nations data around HIV. That data access request has already been approved, and we're just doing the technical work of that data match and then analyzing and commenting on the data, or what we're seeing from that data is happening. But community members are saying, what are you doing with our data? And who's going to know about it? And is it going to affect me negatively? in an unintended way, perhaps, or maybe in an intended way. Maybe you are trying to violate my basic human rights or my right to privacy. They do say that to us. And so, again, part of my job will be to make sure that they have informed consent, that we do everything we can to protect their privacy, and that we remind our frontline workers, our workers on the ground, about their duty around issues of privacy. Historical institutional neglect. Many of our, for instance, I was part of a study in the downtown east side around how many of the clients, Aboriginal clients there, had been to residential school. And they kept telling us, well, no one's ever asked us about our residential school experience. And we thought, isn't that odd? You'd think in the downtown east side, where people have a lot of psychiatric illness, that someone would have asked them about previous historical trauma. And we hadn't. But we were asking, and we found that 1 in 4 people in the downtown east side had been to residential school. The last residential school closed in the 90s. You'd think it was starting to fade away in prevalence in our communities. But 1 in 4 of us in the downtown east side having been to residential school is probably an important issue to discuss. Stigmatization in a number of forms, most notably not just the usual homophobia or phobia around persons with a communicable disease, but for communities, I've literally heard from chiefs asking for access to public health information around who has HIV in their communities so that they can banish them, they can kick them off the res. And so the amount of education that I then need to do with that chief and thus with all chiefs, because if one of them is thinking it, and actually I've had 3 of them ask for that data, if 3 of them are thinking it, how many others are feeling that they have the right to ask for this kind of data and evict their own members? And that involves a lot of education for those leadership. But stigmatization is also really important, an issue with sex workers. We know that the police have harassed sex workers. We know they harass Aboriginal sex workers because they tell us. We know that the police were negligent in the downtown east side, and that the reality of murdered and missing women, many of whom were Aboriginal sex workers, is a real and alive, and it's probably not polite for us to talk about it, but it happened. And so this stigmatization and this harassment by police has not helped, does not help women with HIV who are in the sex trade, and I think we need to talk about it. The idea of microaggressions, I hear from, again, from our clients that they get small little niggling jabs at them while they're in care that make them really uncomfortable. For instance, a worker might say to them something like, well, you get all your stuff for free anyway, right? You get a house for free, right? Or you don't pay taxes for anything, right? So why are you complaining? Just really odd comments that are based in ignorance and that are really just careless and thoughtless and not the domain of the health worker. I don't know why health workers would be commenting on those kinds of issues in the midst of care anyway, but just the whole idea of this kind of carelessness that can be a very real obstacle. Our members are saying, it just doesn't feel like a really cool place to visit. Caregiver ignorance of Aboriginal realities, even the simple things like that the fact that we have chiefs or that there are Métis populations, if caregivers are unaware of those simple facts, those can be obstacles as well. And there are probably a number of other obstacles. This is really just the beginning of a list that could be quite long. I've stolen a couple of slides from Mark Gilbert, where I think he's left now. What a brilliant guy.
He's over there.
Oh, there he is. So good. Oh, I was going to tell a story about you. Guess I can't do it now. I stole this from Mark. It's really quite brilliant and very, very helpful. I love graphics or a single page that can represent a whole constellation of ideas, and I hope that we can indigenize this in our cohort. Certainly, as the Deputy PHO for Aboriginal Health, my framework will try and examine some of these very large-scale ideas and try and make recommendations that can occur at my level that could be of help. And of course, the work that I can do is going to be very different than the work of, say, a frontline worker interacting with clients. Again, from Mark's, this is a really, really good news story of decreasing incidents in First Nations, amongst First Nations peoples. This kind of story is the story that we will be telling to First Nations and Aboriginal people to remind them that their participation would be of a lot of help, that already we're seeing decreased incidents comparing this to, say, Manitoba or Saskatchewan. This is such a good news story. There is a real reason to try and help, because I do think that there is some level of despondency amongst my peoples where they feel like no matter what we do, bad things are going to happen. And we can say, no, actually, there's a lot of good that can come of all of our work together. So this good news story, this data, this picture, this confidence, I think will serve us well. So I hope that this kind of testimony will go out. It would be great to have Scott and Chris come out with me. My gosh, weren't they amazing in presenting, the inspiring story of what's been happening here? And that kind of story could go a long way in our communities to encourage them to work with the stakeholders here. So we have the First Nations client file. The First Nations client file identifies status Indians and their children. We can use this, and imagine that this file used to sit with the federal government, with formerly the Indian and Northern Affairs Canada, and we had to apply to use it, and it would take a really long time. And we didn't use it for 5 years because there was some confusion about whether provinces could use federal data without breaching FIPA or federal confidentiality laws. So that was really quite odd to me that we would collect data but not be able to share it amongst ourselves. We couldn't use it for data matching. So we got our own First Nations client file. We got our own provincial list. It's governed by a tripartite group. It's called TDIP, Tripartite Data and Information Planning Committee. And that committee can use this First Nations client file with all kinds of databases, for example, the BC Cancer Agency's Cancer Registry, or say the BC Centre for Excellence for HIV/AIDS, and we can get First Nations data on things like physician diagnostic codes or hospital visits or PharmaNet data on who's accessing heart and those kinds of ideas. So this is underway. I want to stop and see if anyone has any questions about the First Nations client file. We also have, I'm just going to skip. We also have the Aboriginal Administrative Data Standard. The Aboriginal Administrative Data Standard is an Aboriginal self-identifier set of questions that you can use on intake, no matter where you are. And we are certainly hoping that the BC Centre for Excellence, who has several hundred First Nations or Aboriginal clients, that they could be asking this consistently, effectively, as a good part of their policy, and we would learn from their other demographic data besides their Aboriginal self-identification. The reason for the Aboriginal Administrative Data Standard is so that there's consistency in asking the questions, because if the question is are you an Indian versus do you self-identify as Aboriginal, and if so, do you consider yourself First Nations, Métis, or Inuit? Are you a status, if you are First Nations, are you a status Indian or not? What is the name of your nation? And do you live on reserve or not? Those are some really helpful questions. And there are probably a bunch of others that we would love to ask, particularly around HIV, that would be helpful to us in finding out things like, finding out about these Aboriginal MSMs or these Aboriginal women, particularly in the Downtown East Side, and their particular social circumstances and their particular vulnerabilities around HIV and AIDS. This is just some further information on the Aboriginal Administrative Data Standard. Interior Health has already started to roll this out. Is Brad Anderson here? Rob's here. Is Brad still here? He might have had to leave.
So we're using this in the self-identification program for hospital and IH sites.
Yes, so you've started using it, and you've asked this question of many thousands of people already.
Yeah, there's over 10,000 residents.
Yes, and you've developed a script around how to ask these questions consistently, and your data collectors or your intake workers are ready for the few basic questions that come up, like why are you doing this, and will this affect my care, or will this affect me negatively in some sort of way? So really pleased that that's occurring, and I know that we can learn from that exercise. The Panorama is also another place that's been preparing to collect First Nations data, so some of the prep work in that regard is going to be helpful to us as well. As I mentioned earlier, the PHO office, and as the deputy, I'll be leading this. We will have an HIV/AIDS action plan for First Nations, and it might include, these are just ideas, and we're going to, actually Mary Chu is here. She holds the pen for me in my office, and I'm sure that she's ready to revise this after listening to all of you today already. My gosh, we came up with a number of ideas and areas of action that we could include and should include. So identify policy and systemic barriers to obtaining services. Why aren't pills getting in mouths? Why aren't doctors and other HIV interprofessional team members not being seen? To identify priority action items that are within the scope and influence of the Deputy PHO for Aboriginal Health. For instance, perhaps it's my authority to ask the Center for Excellence in HIV/AIDS to include an Aboriginal self-identifier on intake, maybe, or maybe it's the Tripartite Data and Information Committee.
You mean when they enroll into the drug treatment program?
Yeah.
I think that that's there, but I can't swear to it. I can check.
Yes, I think it's there. I think that the data is not consistently collected, and I think the questions differ slightly from the Aboriginal Administrative Data Standard. We could ask them just in a little finer way. Great. So, I don't. Perfect. That's all it took. Gosh. To lay out stakeholders' roles and responsibilities to enable implementation of action items. We learned this with TB control, that if we state very, very clearly who's in charge of what and who's not in charge of what, that can help us. They can help us with redundancies and help us not bump into each other in the field, and can really clarify roles and responsibilities. That we wish to promote HIV testing. I think it was mentioned earlier that we did try and do this last year. We actually only managed in a year to do a single HIV test in Aboriginal communities because of the phenomenal problems around HIV testing. So there's more that we could do and learn. Most of that was around provider numbers. Who's the physician's number that's going to go on the rec, and who's going to receive HIV positive clients into care after, with a positive test. All communities are asking for culturally competent care, no matter what the disease entity, care that reflects their cultural realities. Support for addressing the social determinants of Indigenous health. It's not just the job of the First Nations Health Authority, I dare say, but probably of some others. And so we should formally ask them to give us a hand. Equitable access to appropriate and supportive medical treatment and care, including what I'm hearing from Rolando, that we may well have a number of HIV positive Aboriginal peoples living in remote areas, like one HIV positive person with a GP or a family physician, like only one in that entire doctor's clinic, which means that those doctors have to get their skills up and that we can send them to that doctor with a lot of confidence. Aboriginal patient navigators, already happening. We already see their value. We know as well from other care models in other countries where there are Indigenous populations, this can help a lot, that these patient navigators, we can also call them community navigators because they would be sometimes speaking out for communities around HIV care and access testing prevention, not just for individuals who are Aboriginal, data gathering and surveillance, formal partnerships, that's where Rob signs on the dotted line and I sign on the dotted line, and we agree that we're going to play nicely together and not scrap and not just forget about things. And knowledge translation and human resource development, that we are able to interface with communities, speak to them in a way that's helpful to them, and that we increase the capacities of their workers on the ground. We know that there are community members like community health nurses, community health reps, even chiefs, who can't, even chiefs, I shouldn't say that. Hopefully there isn't a chief in here who can report to the other chiefs that I was insinuating bad things about them. But chiefs can help us out, and so growing their knowledge, their capacity, their compassion, their skills can go quite a distance. And thanks, Mary, for finding this particular quote around trust, that we really have to build trust amongst our Aboriginal clients. There's a man who came to me last year and he told me, I've watched you for the last 9 months and I realized that you're here to stay, so because of that, I would like you to do a blood screening test for me. Thanks very much.
Good afternoon, everybody. My name is CATIE McDonald, and my partner is Emma Palmatier. As we begin, we would like to acknowledge the traditional territory of the Coast Salish people. And we are going to talk about our experience, our partnership experience with the Northern BC First Nations HIV/AIDS Coalition. We have to show our map. One of the most important aspects, we believe, of providing rural and remote services is understanding the people, where they live, and what their day-to-day experiences are like. This map represents communities across Northern Health, including First Nation communities involved either directly or indirectly in the coalition. Some of the First Nation communities are also involved in the coalition, are also from Interior Health, just acknowledging that our provincial boundaries aren't necessarily always the same as people's traditional boundaries. So this map, you'll see, I hope you can see. Yeah, I think you can see. The yellow stars represent communities over 10,000 population, and the green dots represent communities from 1,000 to 10,000 population, and the red dots represent First Nation communities across the north. A key service delivery knowledge exchange challenge is the small size of many communities. Many communities only have 50 to 200 people. Remoteness and the inability to sustain supporting infrastructure, sometimes such as basic reliable telephone service, high-speed internet, and public transportation networks, as well as human resource issues, present significant challenges to service delivery and knowledge exchange. I was sort of just thinking, you know, how we are so interdependent with the technological world these days, and even within Northern Health, you know, we use internet to distribute a lot of our communications, and just assume sometimes that the rest of the world is receiving them.
Okay, first of all, I want to acknowledge the Coast Salish territory we're on, and I really want to acknowledge Elder Shane Point. I really keep the message that you've given us very seriously, and, you know, coming together is really important. And, you know, like Chiru has mentioned, that I've been in a political position for the past years, as from Macarius County Tribal Council to being a chief for my nation and general manager for a lot of First Nations community. I did business management. But I just want to mention, give you a brief overview of where we come from. And this picture shows the different stakeholders or partners that we have on our task force back June in 2005. And the CATIE hosted a leadership forum. And with that leadership forum, it was really successful. 60 First Nations came together as a result of a CEDAR study that was done, and the finding was that the HIV was increasing. So they really took it seriously, and from that forum, they signed a declaration for action on HIV, and they also recommended a task force be established. So since 2005, the task force was established, and a strategic plan was developed, to develop and discuss with communities throughout the regional consultation. So that is where we come from. And the task force at that time, our vision is Aboriginal people in northern British Columbia will achieve and maintain strong, healthy, and fulfilling lives free of HIV and related issue. And our mission, the task force will support meaningful, lasting efforts for Aboriginal communities in northern BC to address HIV and AIDS and related issues in a culturally relevant manner. So with this, the vision and mission, we've been really, the group has been following this, and I forgot to mention that the task force consisted of different agencies. We were really, like you're talking about engagement. The task force has representatives from Northern Health, Public Health Agency, the Ministry of Children and Family, the RCMP, the Friendship Center, people that are living with HIV. And the past couple of years, we recruited youth representatives from the 5 regions in the north, because as you can see the map, northern BC is really a vast geographical area. So the youth have really been active in our coalition. So that is how we're structured, and we have our quarterly meetings, and the quarterly meetings, every second meeting, we have it in First Nations communities, and that's how we really get the communities to get involved. And I'll be mentioning more about our engagement, and I'll pass it on to CATIE.
One of the key things that we've found about involving First Nations people is the importance of involving First Nations people at all levels, including those affected by HIV, including grassroots, community level, and at First Nations leadership. In the early days of the task force, members of the task force emphasized that involving elders and youth and community leadership were critical if we were going to realize our mission and vision. And Emma Palmentier, as our chair, has been very active politically, and as a past chief for her community is recognized across the north by First Nation leadership. She has intentionally linked with existing First Nation leadership forums, such as the Northern Chiefs Caucus, to bring issues of HIV amongst First Nations people in the north to the front, and also to seek advice from them on addressing the issues and barriers. Education about HIV has been a part of those interactions. And the picture you see there is a picture of the coalition chair, Emma Palmatier, and Dr. Evan Adams, apologies, Deputy Provincial Health Officer for Aboriginal Health, as well as Irene Day, Director of Operations at BC Centre for Excellence, are seen at the Northwest Chiefs Forum in 2011. At this forum, the chiefs were provided feedback on community engagement project, which Emma is going to speak a little bit more about in a minute. Emma mentioned that we meet in communities every other time. Every other meeting. This picture is of the task force meeting in Kitsilus in the Northwest in 2009. One of the ways to involve communities and to stay connected with communities is to go to the communities and hold coalition meetings there. This provides us opportunities to see the communities and to learn a little bit more about their geographical surroundings. It also provides us with opportunities to experience community hospitality and to share food with the communities. Another important aspect is that it provides community members with a bit of insight into the operations of the coalition by being able to witness the business being conducted and learning about actions of the coalition. Meetings conducted in communities is often accompanied by an education session, and this can also build awareness in communities in different ways. I was just reflecting on two situations, or two pieces, I guess you might say, to a meeting that we had in one of the communities. One was a community member stood up and made some comments about they felt that it was important that we didn't allow people affected by HIV to be involved in the traditional gathering of food. And it was a great opportunity because there were people in the task force who were affected by HIV, and I thought that was really neat that it wasn't the healthcare providers or the advocacy kind of people that spoke up in a very clear and caring, objective way to this person, but actual education took place there from people affected by HIV to this person about the realities of how HIV can be transmitted. And that person received that information and was thankful afterwards for that. And another thing that happened at the same meeting is our medical health officer, Dr. William Osei, who's part of the task force, gave a presentation and created a story that he knew from his heritage, that was, I guess that you might say the story was about people taking their own power. And out of that story was created a coloring book in sort of more of First Nations Indigenous kind of way, and there are some examples of the coloring book that I've left out on the table there if anybody's interested. So those are two really neat things that happened at that one community meeting.
So I want to talk about the community engagement, and this is really important, and I'm really grateful for Northern Health to provide the financial resources for me and my staff to really actually go out to the communities. We cover 54 communities, and we really wanted to find out where the communities were at with HIV, the barriers and challenges on the services and programs, and also the other goal is to help communities incorporate HIV/AIDS into their community plan. But it was really reality hit. Like, I'm First Nations myself, and you know, when you get stranded out in an isolated community, you know, people, like I got stranded twice in a fly-in community, one in the Northwest area, and you know, it was too foggy for the plane to take off, and you know, there were people, members that were had an appointment in Prince Rupert, so you know, I gave up my seat for these people to go to Prince Rupert. So this was one example that really hit me, and I always went to the people and I said, what happens in case of emergency when, you know, if the planes can't land or planes can't lift off, what do you guys do? And, you know, they said that they always try to find a way to get some of the people in case of emergency to Prince Rupert. But it was really interesting when I went to all the communities. Personally, I made sure that I personally went to a lot of the communities and just to listen to the people's stories, because one of the things is that our people really like to, you know, informally around the table sometimes just share their challenges and barriers that they face in the communities. And, you know, when CATIE mentioned about, you know, the services, the internet services and, you know, transportation, when you hear of, you know, some of our women that are missing, this is one of the key factors that our people, the young women that are missing, is because of public transportation. So it is really quite an experience to, you know, listen to all the challenges and barriers. And we've finished with this community engagement after meeting with all the 54 communities, and we developed it into a report. And I really want to acknowledge Colette Plasway, who is the program coordinator, who finished the report with the assistance of Dr. Teresa Healy. So out of the report, there was 5 major categories that were identified. And one is the leadership and community support for HIV, access to service, youth, harm reduction, HIV/AIDS programming in the community. Recommendations of these reports were made for federal, provincial, and regional funders, First Nations leadership and communities in northern BC. And people, we went back twice to make sure that the draft report, we made sure that it was verified, that to ask the people to make sure that if this is what they have told us. So once the report was verified in each of the communities, the regional sessions, we finished the report and then we presented to the chiefs at the Northern Chiefs meeting, and it was endorsed by the chiefs at the regional sessions. And then the chiefs recommended that we develop a 5-year work plan and budget. So we just did that 5-year work plan and budget, and we presented it just this past year, and it was also endorsed by the chiefs. So this is one good example of how Coalition has been involved in maintain ongoing involvement of First Nations leadership. I really had connections with a lot of the chiefs. As Chiro mentioned, I was a former chief, so being a northern woman, when I was a chief at the quarterly chiefs meeting here in Vancouver, I used to be always the one that, you know, advocate on common goals and issues that are faced in northern BC. So, you know, when I left the chief position, and they thought that when I thought I was going to take a break, you know, just 2 weeks, I got called back, and some of the chiefs said that I should take on this role as chair of the task force at the time. And, you know, I am so, you know, like really advocating for our people, because, you know, I really have to think of a lot of our people back home, and those that are living with HIV, the challenges they face. And there are some communities that do not have the services and treatment in the north. So the finding out of this, our engagement, is that people are saying that a lot of their members have to move here to Vancouver to get treatment and care. And they're saying that they would like to see their people back in their communities, because the only time their relatives come home is when they passed on. And this was really identified that they would like a palliative and a treatment center in the different regions, one in the northwest and one in the northeast. So with this report, I always make sure, and I told the chiefs and health directors and the members in the community, that this report was not going to collect dust, and that I'm going to make sure that we follow up with an action plan. So I keep bringing that up with Northern Health and any funders, that this is the voice of our people, and this is what the challenges and barriers that our people are facing. The other project that I just want to mention is that majority of the population in northern BC, and I'm sure it's throughout BC and across Canada, is the young people, because we found that there's a lot of, the population is young. So we've been having youth train the trainers in partnership with Healing Our Spirit and Youth Co. the past year. And out of these training sessions, the youth from the communities make recommendation to us. And this is a few of the recommendations that they brought to our attention. And the Youth Coalition members are developing this into a work plan. And the one is youth video poster with youth leaders, youth train the trainers. So these are some of the issues that the youth are going to be working on, and it's in our work plan for the new fiscal year. And next month, we are having our first youth train the trainers in Terrace, and with the financial help of Northern Health and Ministry of Health. This is really reaching out to the young people. So with this Youth Train the Trainers, we want to make sure that the youth are trained to train in the First Nations communities. So being really innovative and creative is what is in the back of my mind every time, there's a project. So one of the things that we did when, gathering the young people was this was one project that we did where the young people were making drums that was going to be presented to the chiefs at the leadership forum. But we had young people, there was a program with the Friendship Center, and the CATIE had a Walk Tall program, and then the City Council had a program for the young people. So they all gathered together, worked one night, and made the drums for the chiefs. So while they were doing that, they get educated, basic knowledge on HIV. So these are just kind of creative ways to really get the young people involved and doing, drum making through just informal setting, and it really, gets a lot of the young people to come to, doing different activities just to learn more about HIV.
connecting with First Nations people in the North also means them being able to see themselves in the education and awareness building material. Northern Health Stop HIV campaign was made possible by the partnership with First Nation organizations, including First Nations, Northern BC First Nations HIV Coalition, as well as Central Interior Native Health Society and Positive Living North, and also from people who are working and receiving services from those organizations. Recently, we had an acknowledgement lunch held and with the participants of the campaign, and some of the people were sharing the impacts to them, their experiences in becoming or having a public profile as a part of this campaign. And there was a lot of positive feedback about that, but they also experienced some negative reactions in their communities. And one person affected by HIV said, if we're not going to stand up and do it, who will? And there was a real sense of pride amongst the people who participated in that campaign, which includes, as you'll see here, is a website. We didn't have time today to present a video, which is part of that website. It's a very moving video, I think, and I see it as very complementary to the one that VCH presented earlier. It's a different perspective, and so the two of them together, I think, are just great. And so if you do want to look at it, it is, if you look at HIV, search HIV 101, it'll come up probably, I think, as the first option. This picture just shows a multitude of logos, and not all of them, but partnerships that we have had with the coalition. And we like to acknowledge also the participation of Tiro Panessa in that coalition. He is, as representing the provincial government there, is very helpful and brings a very nice, what should I say, kind of emulsifying attribute, I think, to the coalition. I could say a few other things too, but I'll just leave it at that for now.
We're short on time.
So we would like to end with just 3 key messages that I think are reflected in the presentation that we've made so far. Based on our experience in partnership with the coalition that relate to the Stop HIV projects, and that is wherever possible, strengthen and enhance existing forums, relationship, and capacity. As you can hear, we've had this relationship for a while with the coalition, and we were able to strengthen that relationship through the Stop HIV project. Another one that I think we've mentioned is that find ways to involve First Nations people at all levels, from grassroots to leadership, and I think the coalition is being very successful in that. And the third one is that First Nations people view health from a holistic perspective. And this is one thing that I found, even being part of the coalition, going to wanting to make presentations right away about Stop HIV and treatment as prevention, and that is addressing HIV requires understanding and addressing the root causes of HIV amongst First Nation people. So we can't just go talk about HIV. We need to talk about some of the root causes, acknowledge them, I would say, acknowledge them, and think about the addressing in a holistic way. So drum making does relate to preventing HIV. And it relates to regaining culture and acknowledging the historical traumas that have been spoken about earlier is a really important part of that. And with that, I would like to say thank you for your attention.
Hello, everybody. Hi. Before we begin, I would like to just acknowledge our elder and for the wise words you shared with us today. Thank you. And to acknowledge the traditional Coast Salish land that we're on here today. So good afternoon. My name is Sarah Callahan. I am Métis, and I work with Chimamac Aboriginal Program at the Center for Disease Control.
And my name's Janine Stevenson. I've had the privilege of being a nursing support for Chimamac for many years, about 12 years now.
So we thought that we would give you, and we're going to try to make this as quick as possible, a brief overview of our program, and then talk about the project that we did that is STOP funded. So Chimamac is a provincial Aboriginal program, and we provide culturally appropriate STI, hepatitis, and HIV education, resources, and wise practice models. We really strive to be creative in what we deliver. And we recognize that building on the strengths that are already existing in communities is an important piece to the work that we do, as well as building on tradition and culture. We also recognize that collaborating with partners is an extremely important piece, and we are a harm reduction model.
So our focus is to provide training to community members and to healthcare providers that are in community. And these trainings provide both the community members and the staff with sort of knowledge, skills, and attitudes which are necessary to create sustainable change within the communities. Chimamac has been engaged with First Nations communities throughout BC. I believe it's longer than 15 years. We had a director at the time at the Center for Disease Control. His name was Mike Reckert, who it was really clear to him the connection between the First Nations people that were residing in the downtown east side and the First Nations people living throughout the different communities in BC. And he, with the support of others, brought together BC's Aboriginal HIV program. So Chimamac has been going into communities for a very long time. And over time, we've sort of grown to appreciate a few things. One is definitely the diversity of communities. It's really a mistake to do big, broad brushes when you're talking about First Nations communities. They are all very diverse in the 203 different communities across the province. And their rural experience is very different from the urban experience. We also have come to appreciate that the importance of, as was mentioned in your talk, relationship and the centrality of each community cannot be overemphasized. It has to really be from the community and from the community members any kind of strategy or initiative that you want to support them in. We also have come to appreciate that communities are at different levels of readiness to deal with HIV and all of its inherent issues. Each community would be at a different level of readiness, and it's been sort of researched up the yin-yang that really, in order to be effective and successful, you have to meet them at that level of readiness in order to move forward. With each project and workshop that Chimamac has conducted, we've done a needs assessment and we did evaluations. So our workshops actually have really evolved over time, trying to respond to the feedback and the evaluations that the communities have given us, trying to figure out if we're actually being responsive to the needs and what kind of successes that they're experiencing.
So as I mentioned before, one of the key things that we have found is that we cannot stress enough the importance of our partner relationships. It's through these partnerships that we are able to engage in relationships with community and with community members. Some of our past partnerships, as you can see Emma up there with the coalition, is a really strong partnership that we have and really value. Northern Health, again, as well as FINI, PHSA, and then we also have worked really closely with CAN, Youth Co, Renewing Our Response, Healing Our Spirit, Positive Living North, Positive Living Smithers, Positive Living BC, CATIE, Community Health Associates, and the list kind of goes on and on. So one of the key aspects for us is engaging in relationship building.
And so the leadership forums that Emma mentioned and Kathy mentioned, the manager of Timamook, Melanie Rivers, has been doing this work for a really long time, and it was really clear to her that if you don't have leadership on board, it does get bumpy and it can get stuck. And it wasn't without Emma's influence and partnership and Kathy's partnership that we were able to put on 2 leadership forums, one for the Northwest and one for the North Central and Northeast. And they were incredibly successful. We were able to do professional photographs and capture quotes of the chiefs who sort of their messaging around HIV and their issues that they wanted to share with their communities. Beautiful books that we created, wonderful, wonderful resource, and incredible moving statements from the chiefs about the kind of messaging that they wanted to get out to their community members. So we're really proud of those two events, and it was done with both Kathy and Emma. Yeah.
So moving into the project that we engaged in with STOP funding, it's called Next Steps, Increasing HIV Testing in Aboriginal Communities in the North. So the 3 nurses that got on board with this were Amanda Porter, who is from the Bonaparte Reserve, Janine, and Sarah Levine, who is now on maternity leave. And so one of the messages that we have continually heard is why aren't those nurses doing testing in the communities? Why don't they just start testing? What's the problem? So this came along, and after many, many years of working in communities, we knew, looking at community readiness levels, some communities had moved past the level of denial and resistance and were now ready to take some further steps. So we wanted to work with those communities using a model that we felt was successful in supporting nurses to increase HIV education, awareness, and testing. So with the support of the STOP funding, we were able to work with nurses and community health reps from 5 healthcare centers who service 17 First Nations communities from northern BC. So our first step was to engage with an advisory group, and we gathered around approximately 10 people from our stakeholders group, which was those groups that I mentioned previously. And we used that group to help direct where the project was going to go. So this was the model, and what we have found based on our previous experience was that it's an evidence-based model, and there are 3 key steps. One is the pre-assessment. So the team of nurses went into those five centers, and they worked with them to figure out what it was, where those communities were at, and what it was that they needed around HIV awareness, education, and testing. They then went into the mentorship piece, which was really around developing relationship. And as we've learned over 15 plus years, developing relationship is a really key aspect. So they worked with each of those 5 groups to develop their individual plan. And then there was a 4-day training where it brought all the teams together, which resulted in a supportive network for them to work to have the support of each other, as well as creating a stronger relationship with Chimamuk. And then the final piece of our model was the follow-up piece. And so the nurses then went back into the communities to do follow-up visits with them, as well as there was a follow-up training with all of the teams where they came back together, and it was to increase support, celebrate their successes, and look at their challenges and how those could be met. As well, and the final piece of this is this was all evaluated, and it was shown to be successful.
So when we went for our first trip up to do sort of what we were calling the pre-assessment, it became really clear quite quickly that there were some extremely valid reasons why the nurses were unable to test. And unable to test and yet definitely motivated and interested to test. We can tell you anecdotally that some communities are experiencing community members coming back who are HIV positive. And there's a varying degree of outcome with that. Sometimes they come back to community and they end up living hidden with their diagnosis. Sometimes they try to share their diagnosis and get run out of town. Sometimes they share their diagnosis, and with these communities, they were really trying to support the community member who was living there with HIV. And it unsurprisingly, there was all kinds of interest now from other community members to get tested. So for the first time in 12 years, community members were like, we would like to be tested in our community place. And then the nurses would go to do it, and there was incredible odds. They all had their own list of things that were difficult to overcome. And because of this model, this mentorship model, we were actually able to work through most of those challenges and barriers, so that we do now have nurses actually offering point-of-care testing in the Northwest. I think, to summarize, the three main points in our experience to sort of keep when you go forward to work with people who are ready to do it is the rural lens is very important. The rural experience is very different from the urban experience. The stigma and the violence that surrounds HIV and the issues that are inherent there need to be understood, because the consequences of ignoring or overlooking it result in violence, being expelled from community, and even death. We lost somebody in November because they shared their diagnosis. And I guess the other really important thing is, it's been researched over and over and over again, communities are at different levels of readiness. If you go and you find out what level of readiness that they're at and work with them on the strategies that they come up with that fit their level of readiness, you're going to have more success and be more effective in raising HIV awareness, education, and testing.
Save the best for last. So can everyone please stand? I've been sitting for a long while, and I want to have your full attention. So can we all get a big stretch? Stretch and do a bit of your shoulders back. Okay, and the other way. Forward. Good. Deep breath in and out. One more time. Thank you. Okay. So, my name is Diana Day, and I want to say Saguli. Saguli is going to go, and that is Oneida for hello, how are you? And my traditional name is Gahandut, and that means end of the field. And I'm very honored to be on Coast Salish territory, and I want to acknowledge the land by saying, let's remember that Vancouver is only 127 years old and are young. And 128 years ago, there were many forests. This land that we're on was filled with game, and I remember hearing a story about Chief Dan George hunting at English Bay. And so if we can just think about what it was like years ago, I think it's really important for us to remember and acknowledge the land that we're on and the people who were here for thousands and thousands of years. It's very important. So thank you for being here today. And I enjoyed hearing all of the great presentations, and I know that I was told I had 10 minutes, and it looks like I'm going to have 10 minutes, so there we go. So my name is Diana. I work with Vancouver Coastal Health with Aboriginal Health Strategic Initiatives, and I'm the leader for community development, community planning. Our No, community development, community engagement. And it involves some planning too. So, okay, great. So I want to talk about some of the communities in Vancouver Coastal Health. We have a region with only 14 communities, and it's very interesting how the statistics defines our communities. And I wanted to say that the urban Vancouver consists of Richmond, North Shore, and Vancouver, and so the area there is 1.6% Aboriginal population, and you know that doesn't look to be accurate because it varies from place to place. And also the Sunshine Coast has a population of 5.4 Aboriginal population, and Paul River is 5.7. And then we go to the sea to sky, so that's the area, Mount Currie, Naquaqua, and then we have 3 communities that are isolated and are accessible only by logging road. And so that's Tamaqua, Skatine, and Douglas. So then we have the Central Coast, and the Bella Coola Valley is a very high proportion of Aboriginal peoples, 51.6 according to the BC statistics. And so there's a wide range of population that we have in our health region. And I also wanted to mention that we have 3 Métis communities, which is really important to mention. We have one in Vancouver, one in Richmond, and one in Paul River. And it's really important that we recognize and acknowledge our Métis brothers and sisters too that are, and we're glad to have one here today presenting, so it's nice to acknowledge them as well. So strategies for expanding care and services for Aboriginal people within Vancouver Coastal Health populations. And so just wanted to mention about community engagement and planning and about the First Nations Health Council and the 5 principles of engagement that they have. And the first one there, or one of them that really sticks to my mind, is about ensuring meaningful ongoing engagement with First Nations, Aboriginals, and leadership. So making sure that it's meaningful engagement, that we have, we get consent and we engage at all levels and different forms of engagement, and that it's ongoing. It's not just a kind of one-time thing, or we don't include them after the fact, but we bring them to the table and we help to make decisions with First Nations. It's very important to do that so that they have buy-in and that they know what their community is like, as many people have said up here. They know what their needs are, and they just need the assistance and the support in order to get things done. So we looked at a lot of reports and recommendations as well that were done in the past, and we've done some of our own, and also conducted some focus groups with clients and users of the services to help us inform our planning and with the STOP team. And also developed some partnerships with Aboriginal organizations and also allied organizations. So some of the key strategies that we used were to increase HIV testing among urban Aboriginal population, because Vancouver is one of the 4th or even 3rd largest urban population in Canada, and Montreal and Winnipeg, and then Vancouver is the 3rd. So we often think about Toronto as being a large population, but actually Vancouver is larger. So it's really important for us to include the urban population in all of the things that we do. Implement HIV testing also in rural and First Nations communities. So that's another thing too that's really important and key, and something that we're working on. And developing some health fair kind of activities in communities, something that's non-invasive, just kind of blending in with the other health fair activities that are happening there, so it's not kind of a standalone thing, but also we're having diabetes testing and other types of screenings going on at the same time, so that folks are not kind of seen as being singled out, and just offering it. So routine, and I like what Chris Buckner had said before about routine testing. The only thing routine about the testing is asking for the test. That's going to be the slogan. So I really like that. that it would be routine, just asking if you'd like to have the test. So it's really important. In communities. So increasing capacity with our communities in the urban area and also in the First Nations rural communities. And then the next thing was about treatment, so increasing the treatment and the care initiatives among First Nations people. And also services, organizations that are serving Aboriginal people. So we have some supports going directly to Aboriginal organizations, and we also have some supports going to organizations that have a high population of clients that are Aboriginal. And also, it's important to note that we have a designated 30% additional housing spaces for Aboriginal people, because we know that many social determinants of health, and housing is one and often some of our people are overhoused, are not housed, and we need to provide supports for them. And so we're looking at, I know that I also sit with the ARC Aboriginal Review Committee, and that's one of the discussions that often comes up is about housing and how can we work with, get our people more allocated, more housing resources. So look, we talked about working with what's out there, what's existing, and some of the urban housing, Aboriginal housing places that are available now, Vancouver Native housing and Luma Native housing, and approaching them and asking them to have some priority for people with HIV. So a lot of different things around what can be done, what's there and what's available. And then supportive initiatives. So another big thing is was mentioned here a few times, and I'm glad I was wanting to include a slide that has Aboriginal determinants of health, and it has housing and a lot of different things, but also has the residential school as a determinant of your health too, if you've attended residential school. Another one is racism, because racism, and I remember someone saying housism this morning too. So racism is a very important thing that we have to, it's very alive and it's very well and living quite well, and many organizations that we have and that we have to work with and that our people have to go to. You know, I myself experienced some racism, very overt, and some that is a little bit hidden. And within our own healthcare system too, it's there, it's out there, and it's alive. So we have to address that. So one of the things that Vancouver Coastal Health is doing is asking staff, and actually it's a provincial initiative about the cultural competency training, but our Stop HIV team has been mandated to, everyone who's on the team takes the training, and also all of our contracted agencies take the training as well. So that's really important. Yeah, and that's a condition of funding. And another initiative is that they seconded me. I was seconded to the Stop HIV team. Community development, community engagement is one of my other roles, the majority of my role. And I've been seconded to this team here to provide some leadership around planning and decision-making around different funding and different activities that take place in the communities. And I also go to the ARC meetings and the Aboriginal Review Committee meeting. We had an interesting meeting on Monday, some new people to the table, which provides some new blood, lots of energy. It was a very informative meeting, and we got some good conversation, discussion going. One of the things that was mentioned at the table was about HIV and about the lack of funding that's available, and some of the communities being remote and not able to access some of the same types of treatment that other communities are able to access, and how. And I was thinking to myself about the smallpox issue that was brought upon our people and disseminated many thousands of our people, and about germ warfare. So it got me thinking about it in a different kind of way, and about how we need to combat this in a different kind of way, and think about what things can be done around HIV, especially because it is so treatable. What else? Yeah, and then we have meetings, meetings, capacity building meetings, and future state meetings. So I'm also involved in those as well. And another initiative that happened was hiring of the Aboriginal nurse educator at Providence, and she's situated out of St. Paul's Hospital, and many of you probably know her as Carol. So going along with expanding HIV testing, care and treatment, there's a lot of things that have been done, and one of the great things is about supporting agencies that are already supporting Aboriginal people. And Vancouver Native Health Society is a very good example of that, and the care and service that they provide to many Aboriginal, not only Aboriginal but non-Aboriginal as well, attend the clinic. And the clinic is open 7 days a week, and they're only closed, I think, on Christmas Day, which is quite amazing. They have a very dedicated staff. So STOP was able to provide support to them to provide to train for testing, and so they're able to provide testing and treatment, and also some support. So there's a social worker there who can work with people who are affected. And also the Positive Outlook program, I'm going to talk a little bit more about those. And Towards Aboriginal Health and Healing is another program at Vancouver Native Health. And also, Portland Hotel Society is one organization that has a large Aboriginal client base, so they also receive some funding to do a lot of good stuff there. And then there's the MAT program at DCHC and the Downtown Eastside Women's Center. So they were wanting to do, they have a nurse over there, I think it's 0.5 a week, or a little bit of time that they get there to help people with HIV, and that was the plan, to do some testing and things there with some of the women that are there. So a little bit about Positive Outlook program at Vancouver Native Health. Their primary mandate is to provide care, treatment, and support services to people who are HIV and clients and family members of them. It's expanded capacity to provide increased ARV supports and services for clients. And then another program at Vancouver Native Health is Towards Aboriginal Health and Healing, and they refer to it as TAHA. And TAHA supports Aboriginal clients with psychosocial, legal, and economic crisis and immediate primary health issues. So there's a lot of issues that people people who are infected and who are living in that area in the downtown east side are having a lot of challenges to overcome. So TAHA works with the people, providing a whole range of different things, from breakfast programs, different food supports, and helping them fill out application, finding housing, those kinds of things. It's really a good program. I think one of the things I was really wanting to mention, some of the great work that's happening with Aboriginal communities and our Aboriginal community, and especially at Vancouver Native Health, because it was brought out at our ARC meeting the other day that it wasn't mentioned in the Towards Health and Healing book, and one of the people said, "Oh, we're doing all this great and wonderful stuff, and it's not even in the Hope to Health." So I wanted to make sure that you all heard the good news. Yes, and then going on to more good news is with the Portland Hotel Society. So we helped to expand the HIV lab and rapid point of care testing at the Portland Hotel Society clinic that they have there. So they're now able to provide that. And so folks are there, they can go to the clinic, they can receive the test. And this also happens at Vancouver Native Health as well. And there was a peer testing project that happened in the summer of 2011. And this was a really interesting initiative that Vancouver Coastal Health undertook, the STOP program, where they were able to train peers to provide the point of care testing, and also had support staff with them. So it increased the awareness of HIV testing through, and also through social marketing, increased the awareness. So some other initiatives, again, was about the the Aboriginal patient nurse educator position, and that position is also to support on-reserve nurses with HIV testing and treatment, and to support patients with links to Providence Healthcare, St. Paul's, and VCH services. And we also have a number of different initiatives with health fairs with First Nations communities. One is with, one that we had in the fall was at Mount Currie, and we did partner with Chimamuk and some other agencies to provide some training for the Mount Currie nurses to learn how to do point-of-care testing, and then went in with a health fair model with lots of different activities happening, and then having people go through the rounds of testing, and then they received a gift bag at the end of that. And we had speakers brought in. A person living with HIV brought in to speak to the people there. And we had another famous actor, since Evan in his other life was an actor, and Dakota from north of 60. Yes, Dakota House. Yeah, so he came in and he was a big draw for the young people. So we were able to get some entertainment and some good food and some testing done for folks there. So that was a big hit. So we're replicating that type of health fair with Squamish and Seashell, and also at Health Six. So we're going to be doing that same thing. So now the nurses in Mount Currie are trained. They know how to do the point of care testing, and they can do it on a regular basis. And that's what we're wanting to do with the rest of the communities, the 13 that we have in our region. What else? The peer navigation programs. So there's some really great peer navigation programs that are happening with Positive Living BC and St. Paul's in Vancouver inner city. And how many of you know the Bloodlines magazine? Great. So there's a really good story in the Bloodlines, and I wanted to bring copies here today for you. And unfortunately, I couldn't do it. But it's really good. There's a story in there, and there's a woman talking about her coming from the north, and she knows nobody in Vancouver, and then all of a sudden this Aboriginal peer navigator appears in her door and was a really, as you say, good medicine. Very good medicine for that woman. So it's good to see that this peer mentoring and peer navigators are doing really good work, good medicine for people who are needing supports from out of town. Here's a photograph of the health fair initiative at First Nations community. So this was the one in Mount Currie, and there's all the smiling faces. So another thing I wanted to mention about cultural competency. So it's an online training. How many of you have taken cultural competency? Great. How many of you would take it again? Good.
That was the right answer, right?
Yeah, so most of you know. Wonderful. So it's there, and there's different modules too that they're coming out with now, and there's different other different trainings. So it's great. I always say I'm also on the district parent advisory committee for the school board, and I say we need to have this education at our school and at each of our school levels, and to have it on the standardized testing so that it'll be taught. So some of the future things that we're going to be doing is to engage and work collaboratively with the First Nations Health Authority, also Aboriginal leaders in our community, and First Nations community, and then expanding access to HIV testing and linkages to care in First Nations communities and also the urban population, and monitoring and improving HIV treatment, care, and supports as needed. And I really like this photo here of a quilt that's made, and it's about remembering people that have gone on before us and who have died from this illness. And I just wanted to take a moment to remember those folks that have touched our lives and that to remember that it is a very real, real thing that's happening to many of our people, and we need to acknowledge them and to remind others that we need to take care of ourselves and each other. So thank you.
So we are over time. I'll see if someone's got a burning question that they just need to, they don't want to let this opportunity pass. I think don't want to not allow that if there's someone that has that. Otherwise, it's just there's so many levels to this, and as Michelle was alluding to in the previous workshop, this is a dialogue that's going to need to continue. She's very keen, the First Nations Health Authority, to be working with the Ministry of Health, and I think a whole host of partners to dig and delve into this, because just hearing all of you speak, there's so many levels to this. I think it's very exciting to hear about Evan's work, literally doing everything in his power to facilitate and make the situation as best situation as possible for success. Hearing about different programs that have worked, different models for collaboration, the work both in Vancouver and in Prince George. There's a lot more that folks need to learn from. I can sum up humbly in one word. When I heard this workshop and knew I was going to be facilitating, the one lesson I learned about engagement with Aboriginal and First Nations people from my time and opportunities I've had to work with the Coalition, even being at the ARC meeting on Monday, in one word, listen. That's it. Thank you all. I was a horrible facilitator in keeping it on time. You were horrible presenters in terms of staying on time. And thank you all for your patience.